hello friends once again, and in this module we will be discussing the palliative management of secretions. And I am Dr. Abhijit Dam, and I am the president of the National Association of Palliative Care for Ayush and Integrative Medicine. Now, secretions, you might be wondering, how would secretions actually be bothersome? Well, secretions actually can be very bothersome, especially if you put yourself in a situation where you cannot cough out your secretions or you cannot swallow your secretions. Then the secretions become very problematic, believe me. In a situation where you are so weak or the patient is so weak that they cannot cough out their secretions, or they are so weak that they can't swallow their secretions, the secretions tend to collect in your mouth, and those collected secretions would drool down, and then they would dry up and they would smell like bad. So, culturally, socially, it does not look good. Physically, it is a distressing thing, because many a times the patient actually drown in their secretions. Now, this was a beautiful study which was done in 2006, and this basically showed that in the last month of life, once the patients approached the last month of life, secretions became a major problem. This was at the study entry, and this was during the last month of life, where secretions became a big huge problem. Now, factors influencing the approach to management of secretions, whether it is oral secretions or lower respiratory secretions. If there are secretions present in the lower respiratory tract which the patient can't cough out, well, then as far as palliative care is concerned, there is not much which you can do, because tracheobronchial toileting is mainly an invasive procedure. You need to put a suction catheter down into the trachea and pull out the secretions, suck out the secretions, which is a invasive and a painful, believe me, it's a very distressing type of thing for the patient. It's painful also. So, maybe at home care, there is not much which you can do for secretions which are present in the lower respiratory tract. For the oral secretions, there are things which you can do, but the secretions present in the lower respiratory tract or in your windpipe in the trachea. So, whenever those are troublesome, because whenever you take a breath, so they rattle with the breath, like ghar, 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 that sort of sound with each breath it takes, that sound will come, and that is what is called a death rattle, and you find it up to 50% in up to 50% cases in the final hours of life. At times, the issue is more of creating an environment less upsetting to visiting family and friends, because the patient is patient is not bothered, because either the patient is unconscious or semi conscious or too drowsy to be bothered about these secretions, but it is very distressing to the family members, right. Suctioning, if you can see it, you can suction it. See it means if it is literally coming out of the mouth, you can suck it out, but if you cannot see it, then blindly putting in a suction catheter can also injure the mucosa and paradoxically increase the amount of secretions. See, suctioning can actually lead to mucosal trauma and increase the secretions. So, I just told you about the death rattle. So, what you need to do is good positioning of the patient. You can give some anti-secretory agents, but once the secretions are already in place, after that giving an anti-secretory agent is not going to help you very much. So, anti-secretory agents like glycopyrrolate, scopolamine is not available in India. You can give atropine, but atropine has certain adverse effects, like tachycardia, causing tachycardia, and too much of atropine can cause psychosis, right. So, this is how this gentleman was in his last few hours of death, and this is how we position the patients, laterally, and this is a towel which is kept just below his mouth. So, all the secretions would come and accumulate in the towel, and you just take the towel and wipe it away and put in a new towel. So, this is how we usually manage secretions in the final stages of life. Well, that was about secretions in short, and coming to cough. cough also, it is a normal but complex physiological mechanism that protects the airways and lungs by removing mucus and foreign matter from airway and is under voluntary and involuntary control. So, it is basically a protective mechanism, but in many types of cancers cough can become a very problematic issue, because the tumor can press upon the airways and cause cough. Cough can be caused by too much of secretions also, right. So, what are the effects of cough? Cough can trigger breathlessness and vice versa. It can trigger vomiting, it can cause exhaustion, it can cause chest and abdominal pain, rib fractures, syncope and insomnia also. So, treatment of cough, if it is a non-productive cough, if nothing is coming out of it, you can give opioids, low dose of morphine or other congeners like codeine. We used to have Linctus codeine. You can give corticosteroids, bronchodilators, nebulized local anesthetics are also used. If there is a productive cough, if a lot of phlegm is coming out and if the patient is able to cough effectively, then you can give steam inhalation, nebulized saline, physiotherapy, gently pat the back or gently do vibration on the chest wall, so that the secretions are loosened up and brought to the main airway where the patient can cough it out, right. If the patient is not able to cough effectively, which is a very common scenario, then adequate positioning like I showed you in the previous picture, suctioning and use of glycopyrrolate. So, this was in short about secretions and cough, and I hope that you have been able to get a rough idea about the palliative management of secretions and tackling of cough. Thank you.